Hello and welcome to another edition of the Osteopathic Lyceum podcast. I'm going to attempt to take a moment to talk to the concept of orthopedic tests or special tests, depending on your preferred vernacular. What I'm going to do in order to talk about this is utilize information from an article by Brent Brooke Bush from the Brooke Bush Institute, Doctor of Physiotherapy, physiotherapist, there's COMT, MSP, SCS, CSCS, that's Certified Strength and Conditioning Specialist, ACSM, I think that's the American College for Sports Medicine. So lots of, at least, credentials, right? So Brent Brooke Bush seems to have quite an impressive amount of credentials. So whether or not that means that what is represented in the article is accurate, that's always up for further investigation, but I think it mirrors a lot of what I've understood across time so that it allows me to refer to what is in this article in order to essentially agree with it with some of the things that I've said in the past on this Osteopathic Lyceum podcast, as well as just in general in person when people ask me questions. So we're talking more or less about orthopedic tests, right? So I'm going to pick and choose, obviously, what I'm reading for the purpose of communicating a concept. There is other information in here, but doesn't necessarily detract from what I'm going to attempt to convey here. So the definition: special tests, aka orthopedic tests, clinical tests, etc. A set of motions, positions, and/or palpations designed to provoke symptoms associated with a particular diagnosis. Most tests are dichotomous, two possible results, resulting in someone exhibiting or not exhibiting symptoms. Okay, so it is, to refer back to this, the point of special tests or orthopedic tests is to provoke symptoms. Now, I will say that some will provoke signs, and usually they will be properly termed, like, I think there's like Phelan's sign and this, that, and the other, right? But I don't even know if that one properly is a sign, because I don't remember the exact test. I think that's somewhere in and around the wrist or hand. But anyways, symptoms are what only the patient can identify. Signs are what everybody, including the patient, can identify. So signs would be things like movement restrictions or lax motion, right? So joint play is lax motion, but you're trying to provoke something. You're trying to generate either a sensation or obvious visualization of disruption of tissue. Okay, I'm going to read again. Results: negative, rule out. Test does not provoke intended symptoms. Positive, rule in. Test provokes intended symptoms. There's, don't need to do that. Necessary prior knowledge. So with respect to necessary prior knowledge, one of the things that Brooke Bush does a good job of is note that depending on where you are and the legal framework in which you are working, there is a lot of liability when you're going to say that something is positive or negative on a orthopedic test, because often there is legal liability and licensure associated with that. So this is to read from necessary prior knowledge as a section. Performing special tests is easy. Interpretation of the findings is more complicated. Are you a licensed medical professional, PT, so physiotherapist, ATC, that one I don't know, DC, doctor of chiropractic, OT, occupational therapist, DO, doctor of osteopathy, this is in America. MD, medical doctor, again, this is in America. If not, then special tests are not within your scope of practice. The knowledge base, so again, continuing to read. Without a significant base of knowledge, example, the minimum standard for a licensed professional, it would be difficult, if not impossible, to weigh the relevance of a special test result. That is, it is not possible to interpret a cluster of subjective science, special test results, and movement assessments if you've not developed an internal model of the healthy ideal, have no experience with what a positive result looks, feels like, are unaware of the potential diagnoses, and are not aware of the prevalence or likelihood of diagnoses. Even licensed medical professionals find assessment/diagnosis a significant challenge for several years after graduation, and every experienced licensed medical professional regularly encounters a cluster of findings that challenge conventional diagnosis. So what I would say is that a lot of that is trying to satisfy legal requirements. If you're going to make anything that would fall under the term diagnosis, in any jurisdiction, if you do not have the appropriate credentials, you just shouldn't do it. Also, with respect to diagnostics and what Brooke Bush writes here, the reality that you will have findings from known tests that do not fall into the conventional diagnostic range is a pretty consistent thing. It's one of the reasons why I talk about using a framework and heuristics as opposed to step-by-step procedural approaches or algorithmic approaches to patient interactions. I'll read again: liability. Assessment and diagnosis using special tests comes with added responsibility. Many licensed professionals have learned red flags or red flag signs. These are findings that suggest a more threatening issue that mandates immediate referral to a physician. In some cases, immediate referral to an emergency room care. One of the more common examples is a low back pain patient who is having bowel/bladder problems and is experiencing sidle anesthesia. In these cases, emergency surgery is the best course of action for reducing the risk of losing bowel bladder control, sexual function, and/or lower extremity strength sensation. If an individual has come to you for an evaluation, you miss red flag signs, you may be liable for the increased dysfunction or injury that results from a delay in treatment. Again, if you're going to be messing around in the realm of orthopedic tests, it means that you are playing with the requirement to refer out when called for. Most of the people that are going to give you cause to turn towards orthopedic results have had very, very severe injury recently or severe report of negative sensation. So major loss of sensation, major loss of function, things like that. These are situations in which it would be intelligent to refer out anyways. If somebody comes in and says, I was in a car accident and I can't move my arm, don't do an orthopedic test. Refer them out. Orthopedic tests provoke symptoms, which means that they are built to generate pain or built to generate strong sensations with a negative valence related often to tissue disruption. The number one red flag when there's possible or actual tissue disruption is don't move it because you could disrupt it more. So if you do not legally in your jurisdiction, as I do not as an osteopathic practitioner in Canada, have the opportunity to meaningfully make any form of diagnosis that would relate to any medical terminology, I should not play in the orthopedic realm. Doesn't mean I don't need to know the tests and what they are and why you would do them, but it does mean that I shouldn't play with them. If somebody is showing up with some indication that I should consider orthopedic testing, I should send them to somebody who can meaningfully do that orthopedic testing, and preferably emergency services in many cases, right? There is something here. What are we measuring? To read again, the most important thing to remember about special tests result. A test result increases or decreases the likelihood of a diagnosis and is not an absolute indicator. To continue to read, results are probabilistic. Unfortunately, there is no such thing as a special test with 100% accuracy. Each test has strengths and weaknesses. The practitioner should view each positive or negative test result as a piece of information that increases or decreases the odds of a particular diagnosis. There are statistical tools to aid in determining the accuracy, strength, or predictive value of each test. Initially, it is unnecessary to memorize the statistics specific to each special test. However, conceptual understanding is helpful for rating or weighing a test result against other findings during evaluation. Don't need to read through the rest of that. Try to get down here. There's something very important. Superficial noting that orthopedic tests have strengths and weaknesses and varying degrees of meaningful accuracy or meaningful use with respect to knowing what the heck is going on, okay? To turn back to this Brook-Bush article, I'm going to read again. The difference between a good test and a bad test. A good test is accurate, valid, reliable, and relevant to the patient being assessed. Okay? I've spoken very much about validity and reliability. I tend to talk about utility. Do you have the time, skill, or resources to do it? Now, with respect to orthopedic testing and osteopathic manual practitioners in Canada, you do not have the legal ability to do it, so there is very low utility. You should just send on. If you have any reason to think you should do any orthopedic testing, you should send on. Send that person to somebody who can do it. Now, to read again, accuracy, the proportion of subjects correctly identified by the test results. Validity refers to how well a test measures what it is purported to measure. Does it measure what we think it measures? Reliability refers to the ability of a test or assessment to produce consistently accurate results time after time, regardless of who is performing the assessment. If an assessment cannot produce consistent results, then a professional cannot determine the accuracy of a measurement, compare that measurement to normative data, or reassess and compare measurements taken on two separate dates. Reliability falls into two broad categories. Inter-tester reliability assesses the agreement or lack of between two or more testers in their assessment. Intra-tester reliability assesses the agreement or lack of between test scores from one test administration to the next administered by a single tester. So inter, between two practitioners; intra, between me and myself. So I do test A at time point 1 and test A at time point 2. Do I get a similar result? Because if I don't, can't trust it. It's not reliable. And also, I need to make sure that that test is testing what I think it is. So if I'm holding the base of somebody's skull and saying I'm assessing the pulsation of cerebrospinous fluid, when realistically the largest movement with respect to what I would get haptic feedback from is going to be generated by thoracic respiration, CSF pulsation testing doesn't pass the sniff test. It has no surface validity, right? Like there's no face validity. It's just ridiculous on its face. If somebody's laying on their back and they're breathing, then you're saying that a low pressure pulsation is going to be palpable above and beyond thoracic respiration, then you don't understand validity in a very unfortunate way. Okay? The relevance, I don't need to read that. Okay, I'm going to read something here. Again, this will be the final thing that I read. How the Brook-Bush Institute chose the special test in these lessons. So this is leading towards essentially some form of teaching element for special tests or orthopedic tests. To read, there are hundreds of special tests to choose from. There's often an overwhelming number of tests for a single condition or pathology. Learning all of these tests is not realistic or practical, and if selection is refined using the concept above, is not necessary. Accuracy. There's more research on the accuracy, specificity, sensitivity, reliability, likelihood ratios, etc. A special test is published. Findings indicate the majority of special tests are fairly poor. In fact, most are so poor that most dysfunctions require a test item cluster to reach an acceptable level of accuracy. The Brook-Bush Institute has purposefully excluded all poor special tests that were not included in a test item cluster. I don't need to read any more than that. Orthopedic testing, no matter where you look, if you actually look, is known to have essentially poor accuracy. Sometimes specificity is decent, sometimes sensitivity is decent in varying realms, but they're so bad that you have to do a bunch of them to figure out if something's going on. Now, also, sometimes what they're trying to do is identify syndromes or conditions. Osteopathic practitioners, unless you're a DO or the jurisdiction that you're in gives you diagnostic privileges, then that's a different story. But the fundamentals of the hands-on profession of osteopathy have a challenge in that the jurisdictions have different rules. What I would say is that the fundamental portion of osteopathy is guided by identification of motion restriction and respect for the barrier concept, aka no protective responses. Don't make them say ouch. So if you think something's sore, don't move it, don't poke it, or approach with severe caution. Somebody's recently been in a major accident or in major pain or had major change in function. Severe caution. Don't do an orthopedic test on somebody that was in a car accident and says that their arm is bruised and very painful. Don't do an orthopedic test. Not only are you going to hurt them, but you could further disrupt anatomy that is disrupted. That's emergency services. So orthopedic tests are known to have major flaws. You have to do a bunch of them together to even get close. In order to get a positive test result, to know that something's happening, or to have an increased amount of confidence that the thing you think is happening may be happening, you have to provoke. You either have to provoke joint movement. So what you're looking for in joint movement type tests is laxity. So the joint moves too much. Well, guess what? If a joint is moving too much, but some amount of tissue is intact, when you challenge it at end range and it does move too much, you may injure it further. When you're looking for things like neurological symptom provocation, so you're trying to make something go numb or tingling, unfortunately, as a hands-on practitioner, even one that is allowed to do special tests and interpret them meaningfully in a particular jurisdiction, you have to rely on patient report. Now, in most cases, a patient that is having numbness and tingling is going to report accurately because it sucks. But it's still patient report. I can't observe it. So guess what? Patient reports numbness or tingling. What do I have to do? Do I just automatically go in and do some form of intervention? No, I need to go for imaging, right? Orthopedic tests, when done and when positive, point towards imaging. They don't necessarily point towards treatment because you have to then go confirm on another level that is appropriate to the particular condition presenting that it's there, that it's identifiable internally via imaging or some other diagnostic criteria, right? So let's just say somebody says there's numbness and tingling. Okay, well, I might have to do some fluoroscopy for vasculature, or I may have to do nerve conduction testing. Osteopathic practitioners, unless you're a DO, or for some reason in some jurisdiction, you have the ability to do that, or you are a neurologist and a hands-on osteopath. Then you do your neurology, and then maybe you can figure some stuff out. But realistically, it points to further diagnostic. Positive orthopedic tests rely on patient report in most cases, aside from joint play. So when you find a lax joint, you found a lax joint, right? And you probably messed it up and it probably needs surgical intervention or tons of time and rehab. But they point to further diagnostics that osteopathic practitioners in almost every jurisdiction cannot do. So orthopedic testing has major flaws. It doesn't do what you think it does. So please excuse the small edit. I actually just had somebody show up early for an appointment, which is wonderful because it was very enjoyable to do. Anyways, rambling on that doesn't necessarily help the point. So to reiterate, so that I make sure that I'm staying on track, and I believe this will be more or less the same thing I was saying prior to stopping the video, but orthopedic testing requires the provocation of symptoms. It requires patient report in almost all cases, aside from things such as joint play and noticing joint laxity. The accuracy issues are very high, such that you really don't know what's going on in most cases with orthopedic tests or special tests. With one test, you have to do a bunch of them or a constellation, and the answer is further imaging anyways, or further diagnostic testing, depending on what the particular test is pointing towards. So if we then flip back and reiterate something that I've already said, that osteopathy is trying to avoid the pain response or protective responses from patients, and depending on your jurisdiction, you really don't have access to the ability to do them, to interpret them. They're not as useful as one would want. Some people think, for whatever set of reasons, that they have high accuracy, high specificity, and high sensitivity, and they just don't. Some of them are decent, most of them are not. They're not that useful, especially to somebody who fundamentally as a professional is trying to avoid the pain response. The hands-on performance of osteopathy really doesn't cross over with orthopedic testing almost anywhere. Some people are convinced that it does because when they learned to be a professional and associate their identity with the term osteopathy, they learned that orthopedic testing was a thing, that it was a big deal, that it was important. Unfortunately, if you observe it, it doesn't line up with osteopathy as a profession, and it's probably not the most appropriate thing to teach osteopathic professionals unless the jurisdiction that they are working in allows them to use them. If that's the case, then you do it as an add-on, because there's a lot of information to try to remember. Even in that Brooke Bush article that I was reading from, it says you don't necessarily need to remember them all. You sort of need to remember the constellations that are going to do something useful for you, as opposed to remember every single one, because there's a lot of different tests and you're just trying to make them say ouch. So if you place any value in the heuristic that I utilize, don't make them say ouch. Avoid protective responses when working with patients. That's how you figure out what to do with respect to the barrier concept. Then why would you want to do it in testing? If somebody, again, as I said already, reports major trauma recently, they have major restriction in motion, and there's visible alteration in tissue, just don't move it, send it on, right? So this ends up really being a simple concept that if you have any reason to think that tissue of some form may be disrupted, it may be torn, it may be broken, don't test it, send it on. If the person is then returned clear of those issues, so they get further diagnostic and you have reason to believe that that diagnostic was useful and accurate, and that person has the motion restriction but not the disruption to the tissue, then okay, proceed with high degrees of caution, be very sensitive, really utilize that barrier concept. But for the most part, orthopedic testing and osteopathy don't really cross over because fundamentally the underlying concepts don't match. And in most cases, advocating for orthopedic testing by osteopathic professionals is sort of counterproductive because they can't use them in most jurisdictions meaningfully because they can't do anything about them. It's just maybe saying, hey, I did this test to a physician. So you say to the physician, yes, this test was performed, there was a positive result, it may warrant imaging. And then depending on the jurisdiction you're in, the physician may be like, what the heck is this thing over here? What's an osteo? And why are they telling me what to do? In other places, you have a positive relationship with physicians and they're quite open and they would bring you on in and have a listen. But for the most part, probably not as useful as one would want it to be, especially if when you learned the profession of osteopathy or identify yourself with the profession of osteopathy, and in that process you learned orthopedic testing, of course you think it's meaningful, of course you think it's important. It just doesn't really tell you what it says it tells you. And that really goes back to the term validity, which you've heard me speak about a lot. If you look at the videos that I have on the YouTube channel with respect to assessment, I'm trying to advocate for very specifically being very clear about what you are doing. I use relational motion, so one thing is still and one thing is moving in relation to it. So we try to keep everything still except the thing we want to move, and then we can say, this particular region is not moving particularly well, or it is moving less than its pair on the opposite side of the body. I don't ask you to interpret specific structures. There's some structures that are very obvious, but I don't really ask you to interpret those deeply because I think there's issues with it. And it would be the same with orthopedic testing. It's asking you to interpret in ways that may not be as ideal. Relying on patient report of sensation has major limitations. It doesn't mean it's not useful. It just means that it has built-in problems. You can't observe the sensation. You can observe proxies of the sensation, but there's also issues with what you're observing because what you observe may not mean what you think that it means. So orthopedic testing, once again, probably not as big a deal in osteopathy as some people would want it to be. So thank you for listening. Hopefully you've learned something. Please excuse the interruption. Hopefully it all sort of sews together and makes sense when I edit it. And we'll talk again soon.